Welcome, everyone. Good morning. As Robbie said, I'm Mark Jones. I'm the Executive Director of the Minnesota Rural Health Association. I'll be your host and moderator for the event today. We have a great lineup for you. We had invited Representative Angie Craig, but unfortunately, she was called into committee work this morning. So if you have ideas for her, please reach out to her. I know she's always open and willing to hear about rural health and always engaged in the conversation. We'll begin our lineup today with hearing from Washington, D.C., Senator Smith's office. We'll also hear from Representative Tina Liebling from here in Minnesota. Hopefully she'll have some good news for us as the HHS bill starts making its way to the final closure. And then we'll wrap up with Q&A with some policy experts from Minnesota and from our friends from DC. And in the middle, we'll have Carrie Cochran-McClain from the National Rural Health Association talk about what they're working on and what they're seeing out in DC. So our first up is Mary Gilbertson. Mary serves as U.S. Senator Tina Smith's Healthcare and Aging Outreach Director based in St. Paul. Previously, Mary worked as Executive Assistant to the Commissioner of the Minnesota Department of Human Services, Legislative Assistant at the Minnesota State Senate, and Constituent Services Representative and Staff Assistant for another member of the U.S. Senate. She holds an MPH from the University of Minnesota and a BA in Global Business from the College of St. Ben's. Mary, welcome. Thank you.
Thank you so much, Mark, and thank you, Robbie. It's wonderful to be here, and I won't take up too much time because I know we have some great experts here to hear from. So thank you all for joining and for the invitation to speak. As Mark said, my name is Mary Gilbertson. I recently joined Senator Smith's office as Healthcare and Aging Outreach Director, and I'm based in St. Paul. And I'm happy to have a chance to tell you about some of the work we've been doing this year. Just to start off, Senator Smith believes everyone deserves access to appropriate healthcare services, regardless of their location. And she's committed to ensuring that we don't leave holes in the net we build to promote the health and wellness of communities. And yet we know there are currently many holes in the net that impede access to healthcare services. And the result is that many people don't get the help they need. As you all know, rural communities face particular challenges, including structural barriers to accessing services, low reimbursement rates, a shortage of healthcare clinicians, and Senator Smith wants to support rural communities in providing care for their residents, improve federal financial incentives, retain the use of telehealth services to expand access, and some of her particular priority areas include ending this COVID-19 pandemic, mental health care access, and maternity care. Senator Smith is deeply aware of the fact that this pandemic has not been the great equalizer, and particular communities have faced disproportionate burdens throughout the pandemic, including rural communities and communities of color because of already existing structural inequities. Senator Smith worked hard to ensure important supports were included in the American Rescue Plan, including $8.5 billion for rural hospitals through the Provider Relief Fund, $500 million for rural hospital grants through the USDA, $7.6 billion for community health centers, $420 million for certified community behavioral health services, as well as funding to bolster the public health workforce, support the mental health of healthcare professionals, aid community-based substance use disorder and behavioral health services, including harm reduction and syringe services, and support Older American Act activities, including the mitigation of social isolation and loneliness among older adults. Most notably, Senator Smith worked to ensure that the COVID-19 testing, treatment, and vaccinations were all free to individuals, regardless of health insurance type or lack of insurance. She also worked to increase funding for contact tracing, vaccine distribution, and vaccine confidence activities. And we continue to remain engaged in this front as our country navigates operational and equitable distribution of the vaccine and now looks toward global vaccination efforts. Senator Smith also believes everyone deserves access to mental and behavioral health care services. And she recognizes the barriers and challenges to accessing these services, some of which include mental health professionals entering the workforce with high student debt, low reimbursement by Medicaid for behavioral health services, and a shortage of providers, particularly pediatric specialists. In addition to the financial investments from the COVID relief packages, Senator Smith has proposed legislation that would support our mental health care workforce by repaying up to $250,000 in federal student loans for mental health professionals who work in shortage areas, improve federal financial incentives by increasing the federal match for Medicaid to 90% for behavioral health services, and use school-based services and telemental health to expand access by supporting partnerships between mental health providers and schools and offering training for school staff on mental health. Senator Smith recognizes that telehealth has been an important lifeline during the COVID-19 pandemic, and our office has heard from providers who indicate that telehealth flexibilities established throughout the public health emergency have reduced no-show rates and barriers to accessing services. She's committed to investing in permanent telehealth changes and addressing the digital divide by continuing helpful flexibilities to supporting access to care. And some of her proposed legislation would require federally regulated ERISA plans to reimburse healthcare, behavioral health, and substance use disorder services provided by telehealth at the same rate as if they were in person. Establish a telemental healthcare demonstration program for individuals in the farming, fishing, and forestry occupations, and remove certain geographic and originating site requirements to allow Medicare beneficiaries to receive telehealth services, including telemental healthcare services, regardless of whether they reside in a rural or urban location. And finally, waive face-to-face requirements for telemental health services. In a time where we've seen an increase in the need for mental health services, Senator Smith is supportive of reducing barriers to accessing services and utilizing the benefit of telemental health care. During the pandemic, many Americans are working from home and studying from home, attending conferences from home, and accessing their health care from home. In order to fully embrace telehealth and telemental health services, Senator Smith recognizes the important and needed investment in broadband. Senator Smith supported several provisions included in the CARES Act passed in January 2021, including $200 million for the FCC to support healthcare providers offering telehealth services during the public health emergency, $100 million for additional grants under the Rural Utilities Services Broadband Deployment Pilot Program, which predominantly supports households located in rural areas without access to the internet. $250 million for the Rural Utility Service Distance Learning, Telemedicine, and Broadband Program to be used for telemedicine and distance learning in rural areas. Permitting the Veterans Administration to enter into short-term contracts with telecommunication providers to provide mental health services to isolated veterans via telehealth or VA Video Connect, with priority given to veterans living in underserved or rural areas. And finally, support for the Small Business Administration loan forgiveness that can be used to cover the cost of utility services, including telephone and internet access. Finally, Senator Smith recognizes that an important area of investment in healthcare begins early on with birthing services. More than half of rural communities nationwide lack hospitals with labor and birthing services. And our office has heard from Minnesotans who have to drive hours, sometimes in dangerous conditions like blizzards, just to get care at a hospital. The disparity in access to care and worse health outcomes disproportionately impacts people of color, and rural communities with more Black residents are at an even higher risk of losing their obstetric services. Senator Smith recently visited Perm Health, which provides about 150 births a year, and spoke with other clinics, including Alamere Health, which provides upwards of 650 births a year. Senator Smith's Rural Moms Act would help clinics like these continue to serve their communities and provide quality birthing services that their patients deserve. It would improve federal collection of rural and maternity care obstetric data, establishing grants to encourage collaboration between innovation networks and expand telehealth resource centers, and establish a rural maternity and obstetric care training demonstration program. Senator Smith recognizes that this year has not been easy for anyone, and that continued investment in communities will be needed as we learn more about the repercussions of this pandemic. She remains committed to uplifting Minnesotans' lived experiences and supporting efforts to ensure equitable access to appropriate and necessary healthcare services. Thanks for your time and for joining this discussion. I'll wrap up so that we can hear from our other healthcare experts today.
Thank you, Mary, and on behalf of all of us at MRHA, please thank the Senator for all the great work she does for rural health. And I hope you can stick around and answer some questions at the end. All right, next up is Representative Tina Liebling. Representative Liebling serves as the chair of the Health, Finance, and Policy Committee in the Minnesota House of Representatives. She represents part of Rochester and is now in her 9th term. She was born and grew up in Minneapolis, got her BA at the University of Minnesota. She later earned a Master's of Science in Public Health from the University of Massachusetts and a law degree from Boston University. Before being elected to the legislature, she practiced criminal defense law in the trial and appellate courts. Representative Liebling, welcome. And I know your schedule is busy, so we do appreciate you being with us today.
All right. Well, thank you so much. I'm pleased that we were able to work this out, and I'm disappointed that Congresswoman Craig wasn't able to make it. But I was very interested to listen to Mary Gilbertson, and she, of course, touched on many of the same themes. The themes are the same, whether it's from the federal level or from the state level. And I just want to start out by saying how grateful I am to Senator Smith and her Democratic colleagues in Congress, because they stepped up. And, you know, we like to be able to be, nonpartisan, but this is an instance in which, unless I misunderstood it, only Democrats voted for the ARPA, the American Rescue Plan, that has gotten a lot of this important funding out to the states. And we are right now, as we put our budget together in Minnesota, we are the beneficiary of a lot of that. And some of it, of course, doesn't flow through the legislature, but the impact of those funds is very, very clear that really we could be in a very, very different position after the pandemic were it not for the willingness of Senator Smith and her colleagues to step up and help us out. So I really, really, really appreciate that. So we are in the final stages here of trying to pass Minnesota's budget. Obviously, the regular session ended back on May 17th, I believe. And so we are in special session now trying to pass a final budget, which we must do before the end of the month, because if we don't, the state will shut down. We're not, this works different than a federal, well, the federal government has this as well, but we are very anxious not to have the state shut down. And we do have a negotiated bill now for Health and Human Services, which is closed. So we're not, the agreement is done and we're in the processing now. And Health and Human Services is always one of the largest and most complicated bills that we have in the state legislature, just by the nature of the subject matter. And I know on this call, I was grateful to get the survey results to kind of get an idea of who the audience is here. And we have many students who are joining us. And I just, this is a wonderful time to be stepping up to become part of the Health and Human Services system in our state. And I'm always really grateful that students are willing to do that, interested in doing that, and interested in tuning in to learn a little bit more about how all this is working. But Health and Human Services as a legislative matter is extremely complicated. And one of the reasons is that there's always an interaction with the federal government, the kinds of things Mary was talking about, that we have to use the money as it was intended to be used, and the way federal money interacts with the state. And this year, that's even more complicated because of these new federal funds that are coming to us and the timing of when that happened, and are having to very quickly make decisions about how we're going to use it and how it's going to interact with our regular state funding. So this has been just an enormous, enormous, complicated enterprise. Add to that the fact that we have, to my understanding, the only divided legislature in the country. So I'm a Democrat, but and Democrats are in the majority in the House. In the Senate, Republicans are in the majority. And this means that these bills, by their very nature, every single one has to be a bipartisan bill with bipartisan agreement. And that's both good because it means that different points of view are incorporated. It also presents an enormous challenge when different philosophies are involved. And but I bring you very good news today, because I think that the Health and Human Services bill that we're going to pass is a fantastic bill. And even though there are always disappointments at the end of a session, everybody, you know, these bills by their nature are always compromises. There are always things we don't get. And yet this is a tremendous bill, and I'll just give you some of the highlights of it, and you're kind of hearing it here first. This is breaking news. So one of the big things in this bill is that we're making significant investment in local public health. So the way public health services are delivered in Minnesota, a lot of it is through local public health agencies. And these have been chronically underfunded, and this definitely impacts rural Minnesota, where we have small counties that really struggle using a lot of their own property tax dollars to try to provide basic services. And the pandemic has certainly showed us how very important it is that everybody across the state have good basic public health services. So we're making a significant investment not only into our current distribution of funds, but we're going to be putting out grant funding for innovation to help especially smaller and less well-equipped public health agencies pull themselves up and figure out how to do things better. And I saw in the survey that your listeners are really interested in innovation. This is to drive innovation in public health services so that the next time we have an emergency, and unfortunately we will, this is you know, this pandemic was extraordinary, but the fact that there are public health challenges is not extraordinary at all. And so we will be able to meet both the daily needs of communities in a better way, but also be better prepared for the next emergency. So I think this is just a huge win in this bill. Some other things we're going to be doing, public personal care attendance for people with disabilities. This has also been a real challenge for us as a state. We know that the people who do this incredibly important work are really underpaid. And we have had workforce challenges in this area for a very long time. Now, granted, putting more money into this area is not going to really completely solve that, because we have demographic challenges and those are not going to go away. We just need more people to be available to do this work, but paying them more is going to help move us there. We're making significant investments and in other disability services as well. And a lot of this, of course, is being made possible by the federal funds that are coming to us. Thank you, Senator Smith and others. So we have work in this bill to work on the mental health workforce. And Sue Abderholden, who's here on the call, did a tremendous amount of work on this. And there is a significant amount of her work to have a more diverse and better mental health workforce. A significant amount of that work has made it into the bill. So very grateful to her and all the others who've worked on this, including loan forgiveness funds, some of which we'll be able to use some of the federal funding for that on a short-term basis. But we all know that loan forgiveness is not the be all and end all, but it certainly helps. And it certainly helps when people want to come and work in a place where they may make a lower income, and having big loan debt is a big impediment to that. And we're doing more about that in this bill. Telehealth was mentioned. We are doing telehealth in this bill. We are putting some funds toward that. We're allowing audio only telehealth, doing some health over the phone. The jury's really out on how much this helps or where the challenges lie. And what we're doing in our bill is we're going to study what happens after, in the next couple of years. We're putting significant resources towards studying this, because especially as this impacts underserved communities, rural communities, it's great if people get better access to services. If you can have a mental health visit without driving 50 miles, that's wonderful. But the real question is that mental health visit really helping you to the degree that it should be? You know, are we creating more inequality by making that available? Is it going to be differentially used so that people don't really get the benefit? These are the kinds of questions that we're asking. And so we're really trying to innovate, but in a way that uses data that really looks at, is this helping people? Is it good for some services, not for others? those kinds of questions. So we're going to be working on that. There's a significant amount of health equity kind of work going on in this bill, especially around maternal and infant health. So we're very excited about that. The Senate was interested, along with the House, in really trying to focus on some of these challenges that we have in our state. We have huge racial and ethnic disparities in maternal and child health. And as Minnesotans, we need every single birth to be a healthy birth, and we need every child to grow up as healthy as they possibly can. This is in every one of our interests, no matter where that child lives in the state, no matter what they look like, no matter what their background. So this is something we're really working on in this bill that I'm quite excited about. And then finally, I will just end with this piece. We have in the bill some language that tries to begin to address the problem of communities, and this is usually rural communities, losing their healthcare facilities. And so we have hospital closure language in this bill. It won't stop any hospital from closing a facility, a clinic, a birth center. But what it will do is require that there be a public hearing, and that those who are going to do the closure have to come and explain to communities what's going on. And there's a timeline in the bill so that communities have a chance to come forward and express their concerns, and a little bit of time to possibly, look for alternatives. So, if it's just to be involved, because we know that oftentimes, for example, I know Mary Gilbertson talked about birthing, a place to give birth. If you're a rural community and there's nowhere nearby that a woman can give birth to a child, what kind of young couple is going to want to move there, choose that as their place to go and live, when the very basics that they will need are not available? So this is really a very wide-ranging, concerning problem if we want to maintain healthy rural communities, that these basic services must be available for folks. And so this is just a very small step, requiring that communities be given a little bit of input when they are going to when there's a threat to lose a very important facility in their community. We have language in the bill coming from the House to give communities a right of first refusal in terms of being able to possibly buy that facility before it gets sold off to somebody else. We weren't able to keep that. That'll continue probably for another year. And this is not the be all and end all. We need to do more to make sure that communities have a say, and that the large systems don't just consolidate and make decisions that are good for them and not necessarily good for our communities in Minnesota. And we are going to keep fighting for that. So I hope that gives you a little bit of a view of what's been going on. I've taken far more time than I usually would. Mark told me I should go ahead and say what I wanted to say. So this is all the breaking news from the Health and Human Services bill. It's a huge bill. There is so much more in it that I can't even get to. And I think you're all going to be, I think Minnesotans are going to be very, very happy when they see what we've been able to accomplish this year. So thank you very much. Thanks for having me today.
Thank you, Representative Liebling. And it's exciting to hear that you've come to an agreement and we have a bill coming, and everything you shared with us is just wonderful news. So thank you so much. And if you can, we'd love for you to stick around and answer any questions that our participants may have following Carrie's presentation. So next up is Carrie Cochran-McClain. She serves as Vice President for Government Affairs and Policy at the National Rural Health Association. Carrie joined NRHA staff in 2020, where she is the head lobbyist for the association and is responsible for driving the policy agenda for rural health for the 21,000 member organization. Carrie has more than 18 years of experience working in federal health policy development, including leadership roles at Health Management Associates, the U.S. Department of Health and Human Services, and the Federal Office of Rural Health Policy. In her previous positions, she has focused on improving healthcare outcomes, promoting health equity for vulnerable populations, and advising on healthcare policy issues. Carrie earned a BA in sociology from Willamette University and an MPA with a concentration in health policy and management from the Maxwell School at Syracuse University. She's currently completing a Doctor of Public Health at UNC Gillings School. Her research focus on access to obstetrical care in rural areas. Carrie, thank you and welcome.
Well, thanks so much for having me today. I'm very happy and excited to talk with this team and be on a panel with such esteemed colleagues. We have worked quite a bit with Senator Smith's team on a range of issues, including maternal mortality, which, as you heard, is a personal passion of mine. So a little bit about NRHA in case you don't know us, the National Rural Health Association. We are a 21,000 member organization. We have a big tent, so we've got a lot of providers and health systems, but we also have community-based organizations, researchers, and other kinds of advocates, all working to ensure rural communities have access to quality, affordable healthcare. And at NRHA, we have been, as you can imagine, talking a lot about COVID-19 recently. I know I've got about 20 minutes here with you, so I am going to fly through these slides and leave a lot of them for you as a reference, and then we can come back and dig in if there are any specific issues you want to talk more about. So there's been a lot done at the federal level, as several speakers have already talked about, on COVID relief. And this is kind of a list of some of the key bills that passed Congress. We have a document on our website that goes into detail about what rural health aspects are in each of these bills. But wanting to share kind of some newer updates for the administration, making sure that they're on your radar, because once Congress passed all that terrific legislation, it means that HHS and other parts of the federal government are now in the implementation phase. So one thing to make sure you have on your radar for COVID-19 response, really looking mainly at vaccine education and allocation. There are resources specifically for rural health clinics, similar to the allocations that HHS did for federally qualified health centers, so that we can get vaccines into our primary care offices. So if you're not aware of that, definitely get in touch and I can let you know more about it. It's operated through the Federal Office of Rural Health Policy. There's also resources going out to rural health clinics and small rural hospitals around education and outreach, and then continued testing and mitigation. As you all know, unfortunately, we continue to see COVID-19 in our rural areas. We continue to see kind of growth and continued increases in incident rates in certain communities. And with the Delta variant kind of coming through, we know that could continue to be an issue. So trying to get resources out to folks. We also know that folks like promotores and other community health workers are a huge tool as we talk about vaccine outreach. And so there has been resources devoted to community-based workers and the role that they play as trusted resources in doing that vaccine outreach and education. And then two other funds I want to make sure providers are aware of. The Coverage Assistance Fund is a way to kind of do a wraparound for providers vaccinating underinsured or uninsured patients so that it can make them whole for that service. And then the claims reimbursement is a direct payment for claims related to testing, treatment, and vaccine administration for uninsured. So there's two different resources there. This is all hyperlinked, so it'll take you directly to pages. Happy to answer questions on that, but I found a lot of providers aren't aware of that resource and want to make sure that you all are being made whole for providing that terrific service in communities. Oops. NRHA has been trying to make sure that folks in our rural communities have the resources they need to do education and outreach around vaccines. And so we, a couple weeks ago, earlier this month, launched a toolkit that's on the website that has direct resources, talking points, fillable templates that you can use to co-brand or just totally create a new document that your organization can use to have those community level conversations. We know and are learning more and more that a lot of vaccine conversations need to be that kind of one-on-one trusted source. So providing resources not only for our healthcare leaders, but thinking about faith leaders and agricultural leaders, recognizing that it's going to take all of us to get rural America vaccinated. And again, these are, sorry, we were talking about real life. We are so living real life right now. These are all hyperlinks that go to additional resources on the NRHA site around COVID-19. I also wanted to talk a little bit about what we're seeing in Congress and a little bit about what we're seeing come out of the administration. So in terms of Congress, there's still a lot of conversation about an infrastructure bill. It's not quite clear what that's going to look like. And so in the meantime, NRHA is continuing to talk with members of Congress about the importance for kind of a broad definition of infrastructure and thinking specifically about the rural needs within that. So these are some of the top kind of areas that we're requesting support in the infrastructure package. Knowing that rural hospitals continue to need dollars to build and enhance infrastructure, making sure that our facilities are safe for individuals living in rural areas. The Biden proposal had some terrific work around broadband, and broadband is one of those areas that I think is just critically important to bring rural communities into kind of the next century here. And so support for broadband and along with that, telehealth services in rural America. We heard a lot in our rural communities about during COVID-19 that workforce was the #1 challenge that people were facing. And so wanting to make sure that we're really investing in our rural health workforce. And in doing that, if you look down at the other areas of interest, we are very supportive of some of the investments in community colleges and other kind of post-secondary education resources that we know are important for educating our rural healthcare workers and allied health workers. And then last but not least, thinking about health, not just as the medical treatment, but as the social determinants and all the things that support us to be healthy individuals, and rural housing being one that is a critical need. Again, the Biden proposal had a couple of different things in there around rural housing, but we would continue to emphasize that as an important part of an infrastructure conversation. Again, you can find a link to our full document on the slide there at the bottom. Oops. I can't remember who mentioned appropriations, but yes, we have entered that season within the federal conversation. So there are, we were very pleased, I should say, back up, that the president's budget had some of the best investments in the rural healthcare safety net I've seen in a long, long time. We were very encouraged by that and hope that Congress continues to act on those recommendations from the administration. In addition, we have 6 or so kind of targeted areas that we are hoping that Congress will support in the FY22 budget. And I'll run through those real quick and then we can talk more about them if you'd like. Knowing what we've been through in the last year and a half, and knowing the health outcomes in our rural communities, we feel strongly that there needs to be an Office of Rural Health within the Centers of Disease Control. And this would be really to be a voice within that organization to help coordinate and lead rural efforts around public health. So establishment of a CDC Office of Rural Health, continued support for maternity and obstetric care through the Federal Office of Rural Health Policy Outreach Program. Investments in rural residency, those programs themselves that then support individuals to come out and do residence in rural areas, knowing we have to support and stand those programs up. Continued interest in the Office for the Advancement of Telehealth, knowing the important role that played in the pandemic and coming out, and knowing the investments and interests people have in continuing that. And then resources looking at our rural hospitals and rural hospital sustainability, and looking at what we need to make sure that those institutions are able to operate and keep their doors open as safety net providers in our communities. I'm going to just go through a couple of these slides pretty quickly because they do get weedy. But the key here, there are a couple of topics that I have. The key here is that I'm going to hit on a number of areas where NRHA is really talking to Congress about critical activity. And within telehealth, we really believe that continuation of some of the flexibilities that we've seen under the pandemic is critical. We know that it has increased access to care in our rural communities, and that providers like rural health clinics and the federally qualified health centers have become not only important distance site providers, but folks that we need to make sure are getting fully reimbursed for those services. And so there are a number of pieces of legislation here that NRHA has supported in that capacity. Similarly, behavioral health and substance abuse is an issue coming out of the pandemic that we know is going to be just take up an enormous amount of bandwidth. The opioid epidemic, unfortunately, did not get better during the pandemic, and likewise other substance use, in addition to just mental health overall, and knowing the isolation and depression and anxiety and things that people are dealing with. So there are a number of bills within the behavioral health space that NRHA is endorsing. I mentioned this briefly, but rural hospital sustainability, we know that in the last 10 years, 138 rural hospitals have closed their doors, and that another over 450 are at risk or vulnerable to closure based on similar kind of financial indicators. And so we are looking at all of the different ways that we provide care in rural communities. And in the December COVID package, there was a new designation, the Rural Emergency Hospital designation, which is essentially an outpatient, it's an emergency department with outpatient services attached to it. And so we are very happy and supportive of that designation, but recognize that there are a couple other areas, we have a couple listed here, that we're hoping Congress take action to help the overall long-term sustainability of our rural hospitals. Likewise, there were some changes to rural health clinic payment in the December 2020 COVID package. And so wanting to make sure that as our outpatient clinic providers like rural health clinics are associated or affiliated with other institutions, that their payment is one that allows them to keep their doors open. And so looking at rural health clinic modernization is another priority we have. Turning to the administration, this is a resource for you. We are in transition in terms of getting new political officials in the Department of Health and Human Services. You'll see that this slide lists a number that have already been Senate confirmed and are in their positions, and others who have been appointed but not yet confirmed. And while new folks are coming in, we have a lot of acting individuals as well. And so wanting to make sure you have access to the names of the career officials who are leading the various operating and staff divisions within HHS. I talked a little bit about President Biden's terrific budget for rural health. And just to break it down a little bit further, as we're talking about the infrastructure proposals, the Biden administration is really looking at the FY22 budget proposal, the American Jobs Plan, and the American Families Plan as a three-legged stool to get America kind of back up on its feet. And so I'm sure you've heard the debate about the definition of infrastructure being used here, but there are a number of investments in both the Jobs Plan and the Families Plan, in addition to the FY22 budget, that have critical investments proposed for rural areas across the country. Another issue that we are tracking quite a bit on, and I'd be interested to hear people's experiences around the health care. So around I think it was the original CARES Act bill, there was the Provider Relief Fund was created to support providers in being able to keep their doors open, kind of providing immediate relief in the pandemic. And that Provider Relief Fund continued to be added to in additional subsequent pieces of legislation, as well as the creation of a new fund called the Healthcare Heroes Sustainability Fund. Unfortunately, as HHS has implemented the Provider Relief Fund, there's been a lot of confusion about how the funds can be used. And we know a lot of rural providers kind of waited on spending money or spent money at a slower rate than they really needed to or wanted to because of some of that ambiguity and just not having the margins to be able to pay money back if they spent it incorrectly. So HHS came out with an updated guidance on those funds on June 11th. And the quick and dirty of it is basically the way they've written the guidance. The majority of rural providers are going to need to return money to the Treasury instead of using it in their communities on COVID-19 relief that we know continues to be an issue. And so we have information on our website on this and are encouraging people to contact their members of Congress to help resolve this issue within HHS. A couple other updates from the administration. 340B is a program that you all, a lot of folks are very reliant on and interested in. We have seen the department take action against some of the large pharmaceutical manufacturers who were abusing kind of the program in the last year. And so we're very hopeful to see some of those changes be put in place and better use of that program for our safety net providers. I think I'm going to skip over the rest of this, and if people have questions on any of it, I'm happy to come back to it. But we are in regulation season, so I'll just spend a quick minute talking about the FY22 Medicare Regs that we've seen so far. The big one, the hospital inpatient PPS. Overall, it's a great outcome for rural areas. There are a couple of things that NRHA is flagging that folks might want to pay attention to. One of those is support for their continued low wage index hospital policy, knowing that that has been a fantastic resource for that bottom quartile of hospitals with lower wage indices. The big provisions or the big changes in this regulation is around graduate medical education. And the regulation is implementing, again, a number of provisions of the 2022 December COVID package that allocated new residency slots across the country. And CMS is implementing those provisions, looking at not only where those residency positions should go or where those slots should be allocated, but also looking at support for rural training tracks, and then adjustments of caps for facilities that have had in the past kind of a few number of residents. So again, I can go weedy on any of this. People have questions on NRHA. It actually should be posting our comment letter on our website today if you want to take a look at it. And comments are due next Monday on that one. Just touching real briefly, because this did come out last week and a lot of folks were interested in, the ACA is still standing after the Supreme Court decision on June 17th. You may recall that the challenge here was around, because the individual mandate was ruled constitutional, that provision, the argument was that provision could not be taken away or severable from the entire law. And the way the court decided is that argument was not valid, and so the law stands. And so at this point, the ACA has survived 3 major challenges before the Supreme Court and is still enacted and still in place. And so as we talk about kind of where we go in terms of coverage and Medicaid expansion and different public options, I think it's important to realize that there are a lot of rural Americans, whether your politics support the ACA or not, there are a lot of rural Americans who have gotten coverage through some of the provisions in the law and continue to need additional coverage within their communities. And so it's kind of an ongoing conversation we are having amongst our membership, and would love to hear from you. And on that note, last but definitely not least, we do our best to talk to members of Congress like Senator Smith, but we know that the most important folks members of Congress want to hear from is all of you. You have more power than I think you probably realize when you contact your member of Congress. And so just a reminder of our 5 rules of advocacy when you do talk to your policy makers, and I would love to hear from the others on the panel if this resonates with you as those policy makers. Then make sure that you have a clear ask for the individual or the staffer that you're visiting and be able to explain it. I know sometimes that sounds real basic, but just going to them with a problem isn't always enough. You need to have a solution and help them think about what they can do to resolve that issue for you. Make sure you're talking to the right person who has influence over the issue you care about, and know who you're talking to, kind of what's their voting record, what have they been passionate about, how can you connect with them in a way that they'll understand and empathize with what you're experiencing in your community. Talk about why it's important to you. What is it going to mean if what seemingly small hospital change doesn't go through? What does that mean to your long-term viability as an institution in your community? And recognize, and this is a good one for me to end on here, be concise and follow up. So recognize that these folks are busy. They've got a lot of people who are interested in talking to them. And so make sure that you can kind of get quickly to your point, and then make sure you follow up with any information that's needed. So on that note, I encourage all of you to advocate with us at NRHA. We have a platform on our website where we have a number of advocacy campaigns where you can go directly to your members of Congress and talk to them about the various issues that we are facing as a community. And then we have a lot of new resources on our website. We have a legislative tracker that's new where you can see all the bills on various issues that NRHA has endorsed in Congress. We have advocacy information, policy papers. And then if you're looking for data to support any of the conversations you're having with political officials, make sure you check out the Rural Health Research Gateway, because that's where a lot of the key kind of peer-reviewed literature that the Federal Office of Rural Health Policy supports is located. And it's someplace I go on a weekly, if not daily basis to get statistics as I'm talking to staffers. And with that, I will stop and turn it back over to Mark, and I look forward to the Q&A.
All right, thank you so much, Carrie, and I'll second the follow the NRHA and everything that Carrie and Josh and Mason and the whole team over there are working on. All right, so next up, Representative Liebling had referenced a survey that we did. We sent this out a while back. Is everybody seeing my screen? Okay, yep. So we'd sent this out as people registered. We got it. The response wasn't huge, but we did get some responses. We basically asked the same questions that we asked in 2019 prior to the conference. And I think it's really interesting that of the responses, the #1 concern from 2019 and 2021 is mental and behavioral health services access. That Sue? And it's interesting because we all know, and we're seeing it, that the pandemic has just escalated the need for these services. And in our rural areas, with workforce and the services being harder to get to, with telehealth coming, maybe there's some light at the end of the tunnel, but I hope to visit about that a little bit as we go on. So our access concerns are mental health, primary care services, and medical transportation, both emergency and non-emergency. And those are the top 3, and they didn't change from 2019. So they're still the top 3 access concerns of the people who responded to these surveys. And then we go into workforce, physician workforce, once again, right on top. And Mary's talked a bit about what the senator has been working on in DC, and Representative Liebling at the state level they've all been working on how do we support rural physicians. Mental health and SUD workforce moved up above nursing workforce in 2021. So whether we're just not focusing on our nursing workforce, but we're hearing stories that this is becoming an issue again also. Innovation. Innovation was the transition from volume to value, and earlier it was innovative delivery models. So there's still a great desire, I believe, to invest in innovation and support innovation and see what happens from local ideas and local collaborations. Of course, finance is always on there, but instead of reimbursement rates, this year, the top concern was in uninsured and underinsured individuals. So I think that underinsured population is starting to take its toll on our providers. So with that, we also asked, so what are some strategies for addressing these issues? Because we don't want to just complain about what's wrong. We want to talk about how we can help with these. So on the finance side, Medicare and Medicaid reimbursement that meets the rural needs and the true cost of providing these services in rural Minnesota. The specific support for rural hospitals and clinics. We've seen a ton of money coming through all these plans that Mary talked about and Carrie shared with us through the federal government to COVID relief. But really what is going to happen as we move out of the pandemic and back into a more of a non-pandemic world. And then paying for values based on quality. That came up 2 years ago, once again, and that goes back into the innovation. So addressing the social determinants of health, that was an innovative strategy for addressing the issues. And I think we're seeing that we're really understanding now how those social determinants of health play on people's health and how the pandemic really brought those to light. So the access to transportation and education and food security and a good job and a safe home, all of those really stood out through the pandemic, and we are better understanding how addressing those will bring a more healthy population. And then the workforce, and once again, financial support for our rural workforce, for education and training, and then those rural residencies. So that's what I have for you. That's what our panelists and our legislators were provided with. That's your input. So what I'd like to do now is I'd like to introduce our panelists. And these are friends of mine, people I believe are policy experts in Minnesota, who have led the charge in Minnesota on so many fronts for years. So I'll introduce each of them, and I'll give them each a chance to share their thoughts of where we're at. And I know Representative Liebling just shared a sneak peek into the HHS budget bill, so they haven't had a chance to see it, but really kind of their thoughts of where we are now and where we're headed to and what they've been working on within their organizations. So our first panelist, and not a stranger to our policy panels, is Mary Krinke. Mary is the Vice President of Government Relations at the Minnesota Hospital Association. She directs MHA's policy and advocacy efforts. So Mary, thank you and welcome.
Great, thank you, Mark. And it's nice to see so many familiar faces, and thank the audience for being here today and choosing to listen to this panel discussion. Enjoyed the state and federal speakers today very much. So the challenges that everybody else has mentioned, I think are very common and not surprising. I'm just going to mention three, and they're ones that we've been talking about all morning: hospital finances, workforce, and mental health. And while these are not surprising or new, I think it's important to recognize that these problems are intensifying. So that's kind of the way I would like to think about these challenges today, is that they're actually getting worse than maybe where they were a couple years ago. So they're just the same problems that we have, they're just intensifying. Just to note here on the hospital finance front, every year we do an analysis of the hospital finances, and this information is a year old because it is all audited. And the last year's median operating margin was 1.4% for our hospitals statewide. The year before, it was 1.7%. Previously, it was in the 2% range. Previously, it was in the 3% range. So hospital margins throughout Minnesota have been dropping. I just want to note there were 31 hospitals that had negative operating margins. 2 were in the metropolitan area. No surprise after our discussion today, 29 were in the rural area. So of the hospitals that did not have a positive margin, 29 were in the rural areas. So why is that? Well, there's more elderly folks in rural Minnesota on Medicare. We also have more people that have self-insurance. They buy their own insurance. They don't have a big employer. They're in the individual market. They buy their own insurance. And so many of them are buying these high deductible plans and they just can't afford to pay the deductible. And then that becomes bad debt frequently for providers. Often the service lines that these smaller hospitals are in and are able to provide are the ones that have less margin as well. You still have to buy the same equipment. You still have to have some of the same basic staff, and you can't spread those costs over larger volume. The second issue, and everyone else has talked about it, is workforce. I have found it interesting that this year in particular, we've always had a physician shortage. We've always had a nurse shortage. And this year we're hearing much, much more from our members about not being able to find nurses' aides, food staff, environmental cleaning staff, that now the workforce shortages are throughout all hospital employees and not just the higher skilled professionals. And on the last issue that are the challenges is mental health. There's simply more demand for services than there are providers in supply. And I know reimbursement is part of it, but it's beyond that. We just simply can't hire enough staff. I heard this week from one of our members who was so happy they finally were able to land a psychologist to be on their staff. They had been trying for 1.5 years and they kept raising the salary. And so it wasn't just about the money, it was there's not enough to get. So here we had this hospital that was in celebration because they finally got a provider that they had been trying to hire for 1.5 years. So that's kind of the challenges. And in my last minute here, how do we think bolder to maybe come up with some possible solutions? I used to think that telehealth was about providing better access. I have switched my thinking. I now think that telehealth is about stretching our workforce productivity. Can we get in another person? Would a provider be able or willing to work from their home one night? They may not be willing to go to their office and provide counseling appointments, but maybe they'd be willing to work from their home one night. So can we think of telehealth as not just about greater access for patients, but how do we stretch our limited workforce? Infrastructure, and this maybe will be my last point I want to make. Many, many years ago, the federal government did a Gilbertson bill that pumped a lot of money into building hospitals and infrastructure. And maybe we need to rethink what is infrastructure. The federal government's going to spend a lot of money on infrastructure. Maybe we need to think about, are hospitals and healthcare facilities really part of what makes a vibrant community? What is it that makes a rural community vibrant? So I think we do need to think about loan forgiveness and new relationships with our payers, both state and federal government. So more on that last topic, but I want to let other people jump in here. So thank you, Mark.
Thank you, Mary. Great stuff. And I hope to see some questions and comments in the chat box because I'd like for these folks to answer your questions and not mine, because I don't know if my questions are really as deep and interesting as what might come out of our audience. Next up is Buck McKelpin. Buck McKelpin's worked in government relations for over 25 years. He's the owner and CEO of McAlpin Consulting and has partnered with Libby Law Office in St. Paul. Buck owns Transmedic Medical Billing with his wife, Cindy, and has worked in the healthcare arena since 1985, starting as a paramedic for North Memorial Healthcare. Buck is an active lobbyist. He works with the Minnesota Ambulance Association, the R80, the non-emergency group, and works with all of these panelists on here. So, and he is a board member of the MRHA. So welcome, Buck.
Thanks for having me, everybody. I think so we can get to questions too. I'll kind of try to keep things short, but I think I'll focus on the ambulance, the emergency and non-emergency, which again has showed up in surveys year after year after year as an issue. And the The COVID issue hit both those industries very dramatically. The ambulance industry in the metro saw about a 50% reduction in their volume. Most of these are fee-for-service operations that depend on revenue, like Mary explained, around hospitals. And secondly, the non-emergency group, the R80 group Mark referred to, that's about 7 or 8 large rural non-emergency companies. I call them mom and pop companies that have about 600 vehicles. Sue knows this well. She chaired our non-emergency group for quite a while and worked with us on that piece, but that's always been an issue. It's been tough to get our hands around. Chair Liebling knows this quite well, and Chair Benson and others, is the non-emergency issue. It gets complicated, and it needs a lot of work to help move it forward, because that's a group that provides access that keeps showing up to surveys. Mary talked about some of the COVID funding too. Surprisingly, very little federal money came through for the ambulance industry. As much as there was quite a large federal lobby with the International Firefighters and the Ambulance Association, there were some requests for about $60,000 per vehicle around the country, and none of that money came through. A little bit of money came through based off your Medicaid population. That was for fee-for-service, but they really saw very little. Again, the Minnesota legislature stepped up with that couple $100 million at the end of last session. That did go to the ambulance services, but not to the non-emergency providers. And their payer mix is about 90% Medicaid in rural Minnesota. We pushed pretty hard with DHS to help with that group, and nothing really happened on the Department of Human Services side. I do have to say the health plans and the county-based purchasing plans stepped up. Some of them doubled their rates to keep them in operation. And I can honestly say today, if the health plans wouldn't have stepped up during this last 8 or 9 months, many of these providers would have closed their doors permanently. 2 of them out of the 8 today have them up for sale, and they're talking of closing them down. And these are 2 companies that have between 75 and 100 vehicles. And they're the ones that keep the network for all the health plans through the state. Worked on some legislation about rate stuff a little bit in session. The Department of Human Services and the governor's proposal had a proposal to move the entire state to a broker program. I believe that's out of frustration, trying to figure out what to do with the non-emergency group. But that also had quite a cut in their rates, which I would say today the non-emergency group probably needs to double their rates to be able to stay into business. So one thing that was very interesting that passed in the tax bill that we worked hard on is special EMS and fire taxing districts. Rural Minnesota, our providers see between 70 and 80% Medicare and Medicaid payment rates, which are roughly about $250 below the cost to offer an ambulance ride. So that shifts to the commercial market, and everybody on this call knows about the shifting and how that works with payers for all of our healthcare system. And the industry has finally came together, whether you're fire-based, you're private, you're hospital-based, or you're not-for-profit, to say, we need to have a tool to go back to the local tax base to be sure people get an ambulance 24/7. I think a few things that folks should rely on is if they call 911, police, fire, or EMS show up. Mark that works close with us on this in rural health, I can't guarantee today there's parts of the state you call 911, an ambulance would show up. I know we have quite a shortage of non-emergency, but I can tell you I can't guarantee an ambulance will show up. So we have lots of meetings starting this summer about how we launch some of these special taxing districts. The other things we'll work next year with Chair Liebling and Benson on, as we've just began and are engaging Sellers Dorsey to work on a Medicaid surcharge for the ambulance industry, and where we can leverage the difference between the current Medicaid surcharge and our upper payment limit of the 5 commercials. We do it for governmental ambulances, which brings in about 30 million a year now for the 108 governmentals, but we have to help the other ambulance services with the underpayment of Medicaid rates. So we're doing some modeling on that now as an industry to try to work things with that. And I think Mary's comment on workforce, about 30 of us sit on an EMS rural sustainability. We have a huge workforce problem. Chair Liebling held a hearing right away in session with Representative Hewitt, who was an emergency medical technician by trade. And I think we heard pretty loud and clear across the state that we have quite a shortage. And our other piece with the special taxing district, as an industry, the ambulance industry knows we need to start to consolidate some of the smaller operations, and we need to pay people to staff ambulances. We've all worked for years with our volunteers. They're great people. They're always going to be part of our system. They're still about 35% of the EMS makeup across the state, but we're going to have to figure out a way to pay people to staff ambulances so we're sure that people have access to transportation. So look forward to questions after this, Mark and everybody.
Thanks, Buck. All right, now on to Sue Abderholden. Sue is the executive director of NAMI-Minnesota, which she's been in the position for 20 years, nearly 20 years. She has over 40 years of experience in creating public policies to improve the lives of people with disabilities and their families. She's won numerous awards for advocacy. She received her MPH from the University of Minnesota and her BA from Macalester College. She's a community faculty member of the U of M School of Social Work, and we're happy to have her with us today. As the conversation has gone, I think you have a lot to share. So thank you.
Thanks so much, Mark, for inviting me. So one thing to just kind of put out there is that our mental health system is not broken. If you look at the history, it's never been built. And I think that's just an important thing to remember in terms of moving forward. Prior to the pandemic, our mental health system was very fragile. On edge, really not able to meet all the needs, but we were finding things that worked and we're trying to build on them. The pandemic, as we all know from CDC studies and everything else, has really negatively impacted people's mental health. So we've seen increases in depression and anxiety, a great increase in terms of substance use disorder, especially alcohol use. And while we've all been kind of in the same ocean, we have not been in the same boats. And so I think it's really important to note that the pandemic hit people from the BIPOC community disproportionately in terms of who became infected, who had to be hospitalized, who died from it. And then we add in things, you know, like George Floyd's murder, the attacks on people who are Asian in terms of being blamed for the virus, just really added trauma and stress to those communities. And I think we just have to remember that in terms of how we move forward with everything, frankly. I would say the number one issue that we are most concerned about right now is children's mental health. We had some very good things going in terms of schooling to mental health, which really helped in rural areas. So families didn't have to worry about, you know, driving, taking off of work, how to even navigate the system. And with our schooling to mental health dollars, the funding goes to the mental health provider who then co-locates in the school. We're in a little over 50% of actual school buildings, but the waiting lists are long. By November, there's waiting lists. And so, you know, people are like, well, we're opening up the schools. That is not the solution to children's mental health. I just want to put that out there. These children have gone through a very traumatic experience. They're not just going to come into the schoolroom and be like, oh, great, everything's fine. Everything isn't fine. And if they had family members who died because of COVID, that hasn't been addressed. And so, you know, we have to figure out how to really help. On top of that, we have kids who are boarding in the ERs of emergency rooms for weeks. Not just a day, but for weeks. And the calls to our office have increased significantly on this particular issue. We do not have enough inpatient psychiatric beds for children, period. And even from the metro area, people are being driven to North Dakota or frankly being sent home when the families don't have services to be able to support their child at home. We just lost one of our new psychiatric residential treatment facilities. That was an important level of care so that children didn't have to go out of state. It was a way for children to leave an inpatient unit and go to a level of care that could help them. And so this is just a huge concern to us that we have more kids than ever that are going to start struggling with their mental health. It's going to come out in the classroom and other places, and we absolutely do not have the capacity or the services to meet those critical needs. The second issue I would raise is crisis coordination. So all of the focus on public safety issues, not using police when we don't have to, and all of those kinds of things. We have had mobile mental health crisis in our state in all 87 counties for years, and somehow nobody knows about them. And so we want to make sure that with 988 coming, And as we try to build our mobile crisis system, that we don't start having little departments here and there, just hire a social worker. You know, you have to keep records. This is probably not the only time someone's going to call. So we really want to encourage communities to actually be working with their local mental health crisis team so that we're building the capacity of that team. And if you look at, you know, Buck talked about funding, you know, EMS 24/7. We don't even come close to funding crisis services to truly be 24/7 and to go out on every single call. And in rural Minnesota, frankly, that's just not going to happen. The distance is too great. And so we're going to need things like, you know, tablets so that if a police officer is there, they can connect with that mental health professional. And then the third issue I want to mention is workforce. It is just huge, and I appreciate both the House and Senate working with us on this. We need to diversify our workforce, but we also need to make sure that our current workforce can actually work with anyone who comes in the door. And so that means a lot more work on becoming culturally informed. One of the things that we realize in working with the health department is that we have a lot of people who are graduating from programs, but they're not getting their license. And so we really wanted to look at that issue. A lot of it is about supervision, having to pay for it, having to work for free. And so we did try to address some of those issues in our bill this year, but we'll be coming back, and continuing to work on this issue, because even if we put a lot more money into our mental health system, we could not hire the people to actually carry out the work. And that's a huge problem. And lastly, I just want to say that, again, we do know what works. And one of the, I think, best program we have out there is called First Episode Psychosis Programs. And we think it should be expanded to first mood disorders. So with schizophrenia being one of the most disabling conditions in the world, right, and happening to our young adults, 18 to 26 largely, we don't do anything. If they're lucky, they get to see a psychiatrist. Maybe they'll get hospitalized and put on some meds. That is not how you treat one of the most disabling conditions in the world. First Episode of Psychosis programs, evidence-based, really works. We've seen numerous kids go back to school and back to work by being a part of this program. We need at least 8 in Minnesota. We only have 4. Only 1 is outside the metro area in Duluth. When we have a solution for such a huge issue that causes multiple commitments, right, involvement with our criminal justice system, homelessness, and we don't fund that kind of evidence-based program, is really frustrating to us. So a lot of work left to do in the mental health system, but I will say that we know what to do. We just need to do it. Thank you.
Thank you so much, Sue. Our final panelist, last but certainly not least, is Steve Gottwaltz. Steve is the Executive Director of the Minnesota Association of County Health Plans. He represents the state's 3 county-based purchasing plans, which serve more than 90,000 people in 22 rural counties. He has a very diverse background, including communications, health and human service policy, and government affairs. He served 9 years on the St. Cloud City Council and 6 years in the Minnesota Legislature, 2 of those as chair of the House Health and Human Service Committee, or Health and Human Service Reform Committee, excuse me. He served as our executive director with MRHA for 3 years prior to me, and has served on the Legislative Healthcare Access Commission, the Governor's Healthcare Transformation Task Force, and the Minnesota Department of Health's Rule Advisory Committee. He's a graduate of College of St. Thomas. He and his wife, Paul, live in St. Cloud. They have 5 children and 7 grandchildren. Steve Gottwalt, thank you and welcome.
Well, thanks so much, Mark, and appreciate the Rural Health Association. Just to shout out, we need a strong rural health association in the state as we talk about how we address policy, how we get the right things happening in rural health and rural health advocacy. We need a strong rural health association. So all of you staying engaged and involved is really important. A shout out as well to the Rural Health Resource Center. Fantastic people doing amazing work. National Rural Health Association. Appreciate what our legislators are doing. It's been a tough session, I know, for everybody. I want to focus quickly on a theme here that I used to carry a lot when I was with the Rural Health Association, and that is If you find something that works in rural Minnesota and in rural health, throw fuel on that fire. And all too often we see that not happening. Somebody in Washington, some people in St. Paul think they've got a better mousetrap or a better way of doing things. We know out here in rural communities and rural counties what works. The organizations that I represent do some heroic work. And the plans that I represent are county-based. They're owned by the counties. They're run by counties, county boards of commissioners. The commissioners sit on our boards of directors. So it's neighbor helping neighbor and helping people in need in particular with public programs. And so for 40 years, this has been working extremely well. It's been an outstanding solution for rural healthcare. Again, doing some incredible work in all areas of healthcare. And yet time and again, we see metro-centric approaches, people wanting to take it back to St. Paul or take it back to DC. And we spend an awful lot of time and energy trying to remind people that what works well in rural health, what succeeds in rural health is local. It's local, local, local. We need local people. We need local transparency. We need local accountability. We need local innovation. And you've heard that from the other panelists too in various ways. The kind of innovation that happens in rural communities, in rural counties. That's what's keeping healthcare going right now in this frayed and in some cases falling through fabric of rural healthcare. So I'm here to throw fuel on that fire, to say that we really need to strengthen and emphasize local solutions. County-based purchasing plans, again, delivering care to over 90,000 people on public programs. We know all the statistics, right? I mean, rural is less healthy, less wealthy, older, workforce issues, distance issues, transportation issues, and all of that being solved in many ways by local efforts. So we really need our congressional delegation and our legislative delegations to understand, focus on what's working in rural and help fund that. Jan Malcolm, our health commissioner, recently said that one size does not fit all, and that needs to be reflected in programs from the very beginning, from their inception. And so I would just encourage our policymakers to do that. Focus on what you know is working in rural health. Find ways of helping that local innovation happen and continue. That's how we sustainably address rural healthcare needs. And so I'm proud to be working with our association. I love wearing the white hat. County-based purchasing and county plans do an absolutely fabulous job and are really part of the solution in rural Minnesota. Look forward to some of the questions and the conversation, and great to see so many of my good friends in the battle for better rural health.
Thank you, Steve. All right, this is your time. This is your chance to ask questions. I come from a rural EMS background, nearly 30 years in the industry. I've worked closely with Buck and with the Ambulance Association. And it just seems like the challenges of rural EMS keep making the front page news. I mean, in 1 week, I found 7 headlines about rural EMS and how the doors were closing and the service was shuttering, and there was going to be no more of it. To make that worse, at the end of 2020, we actually had a rural ambulance service in Minnesota shut their doors. Thankfully, the neighbors came in and helped out, took over, providing the service to the community so that when 911 is called, somebody goes. And Buck made a great, he alluded to it, that we're hopeful that when you call 911 in rural Minnesota, that an ambulance service responds in a timely manner, but it's getting more difficult all the time. So my question is, where are we both in DC and in St. Paul on really addressing the issues facing our rural EMS system? And I'll just leave it at that.
Good question. No.
Mark,
you know-
you go ahead, Buck, but I have a comment too, so.
I think Sue's conversation about mental health, the community-based care, and what Steve said around North Dakota did a huge project with rural health. They brought in a consulting group for about 1.5 years, and they really went into local communities, met with city councils, county officials. Back to Steve's comment that things have to be fixed locally. And I refer that back to, it's like, we know we need to do a lot of work to take pressure off EMS around mental health. Nobody likes to put somebody in an ambulance in Cloquet and drive to Fargo for an open bed. Sue's right. We got to keep building the system as we go along. So all that stuff comes into play, not just money to pay for EMTs, but how we take some pressure off the current system. Because now that we're past COVID here, again, the ambulance volumes are going back up through the roof. And a lot of it is mental health and substance abuse. I saw a congressman just recently rode with the Hennepin County paramedic rode with the ambulance for 12 hours. And he said that all of our calls were behavioral health or substance abuse. He didn't talk about shootings, car accidents, heart attacks. He said all the calls we went on, 14 of them over a 12-hour period, there were some domestics in there, but substance abuse and mental health. So I also think that we've been an industry that's not very good about, I'll use the word begging or saying that we need to have the help. I think the special taxing district is a piece, but nobody likes to have their taxes increased. And I also think a non-emergency is probably the best example. It's okay to talk to the local providers about what works. I have experienced it way too much with state agencies that if you're the provider, you're the crook and you don't have the solution. It's about how you milk more out of Medicaid. And I can tell you that's not where providers are. They can tell you they want to cover their cost and be able to have a little capital money to buy new vehicles and keep providing services or anything else we do in healthcare. But we're in this prime example right now at the state legislature. Lots of smart people are all shoved out of the room while a handful of folks are designing state policy. That's a horrible model to be in. And we should all be embarrassed in Minnesota that that's how we're coming up with these budget deals, because that's not solutions. And that's what we have to work on the next few months or years to really have a conversation.
Here, Buck.
Sue knows how to fix it. Steve knows how to fix it. I got 28,000 EMTs and paramedics out there that can tell you how the system works. But somehow a half dozen people think they have better ideas than 5.5 million Minnesotans. And we should be embarrassed as a state that that's how we operate.
Mary, you had a comment?
Yeah, I thought that Buck's comments were very good. So I don't know if this is the final comment here, but if this is my closing remark here, I think we actually need something at the federal level, and I know local solutions are good too, but I think we do need to think about how we reimagine our emergency rooms and EMS. I think we need to think of them more like fire stations that receive public support, and you hope by God you never have to use them. Because right now we have a model that the only way the emergency room can bring any revenue is if somebody comes in and we can bill a payer. Well, we need to have an emergency room ready even if nobody comes in. Okay, so we have some of our rural hospitals, and I'm thinking about this as being the rural conference. We have a rural hospital that needs to have an emergency room up and ready for something bad that happens, even if there's 5 hours that nobody comes in. Okay, and you have to have a level of preparedness. And I think if COVID has taught us anything, we need to have a level of preparedness in our emergency rooms, even if there's nobody to bill. So I think we fundamentally need to have some type of ongoing payment that just stabilizes EMS in the emergency rooms so that they're not dependent on just billing somebody. They just need to have the services available there. So that might help with the mental health issue too, Sue. I think that we need something like that. And I'm not saying all hospital services should be like that, but something structurally for an emergency room presence that gets ongoing funding regardless of who comes in the door. So,
and along those lines, Mary, another thing that we need our federal and state lawmakers to understand and help us with, and not just by massive waiver proposals, but we need the flexibility in funding. We need support from the federal level. We need support from the state level, but you need to allow the flexibility to allow communities and counties and regions to do what makes sense for their people best. These one-size-fits-all approaches or We're going to try to do it this way, and then suddenly we realize we've gotten perpendicular with something that was working well. That's really counterproductive. If we could have more flexibility, and I think accountability for outcomes, flexibility in funding and accountability for outcomes, I think is really important. And I just want to second very strongly what Buck said, and I think all of us nodded, about bringing people into the room to help problem solve instead of always having kind of the three kingpins making the deal at the end of a legislative session. It's got to stop. We got to break the cycle.
If I could just add one quick thing, and as we look at building our mental health system, please integrate it with healthcare. No one knows the mental health mobile crisis numbers in the state, but everyone knows 911. 911 should be sending out the mobile crisis teams. No one is going to know a little building off somewhere that, oh, you can bring a mental health emergency there, but not 24/7. Everyone knows the ER, and we can have psych ERs, and we can have the mobile teams meet people in the ERs and do that assessment. But people keep thinking of doing these separate things, which just doesn't work.
Exactly.
It's healthcare. Build it as part of that.
Thank you, Sue. Carrie, thoughts?
Yeah, well, I mean, I second what everyone has said here, and agree. Not only that it feels like EMS is popping up as a issue that is if anything getting worse, not getting better. I think I really liked both Mary and Sue's comments on, from the federal level, we've been working with Representative Sewell in Georgia, and there is a bill that's out to, kind of extend the rural EMS add-on payment. But those feel kind of like Band-Aids, right? I agree that it probably needs a full reworking of that system and thinking about how we want to restructure it. And, that's something that, to the extent that folks have ideas and want to do some brainstorming with NRHA, we'd be happy to do that. And then, I think for the mobile crisis units, it's something that where we see it working well, it's just such an incredible resource. And I agree that it really makes sense for that to be a critical part of the conversation. So appreciate you kind of flagging this, Mark, as something for us to all focus on.
Thank you, Carrie. And Mary, any final thoughts before we sign off?
I just want to say thank you again for inviting me to this discussion. I grew up with this exact room of panelists teaching me about the healthcare policy and needed changes in our system. So I'm really honored to be here amongst all these experts, and just want to second, there's Minnesota in the American Rescue Plan, there was a bump in incentivizing states to take advantage of the mobile crisis unit model. And Minnesota already has, as Sue mentioned, taken advantage of this system for several years. And it is, as Carrie said, super exciting. Senator Smith has been hearing a lot about from folks in Virginia, Minnesota, that have a really great group of people coming together to provide mobile crisis unit service in that area, and just really uplifting and bolstering that infrastructure is so important. So thank you all for what you're doing, and I'm happy to connect with any folks offline here. I just want to give a shout out to all the students as well. It wasn't that long ago that I was in grad school, and I just want to say, please get in touch with your representatives, and I'm happy to engage with everybody. So thank you for being here.
All right. Well, thank you all. And I think if we can take one thing away from this conversation, Tay, that's innovation, and that the best solutions start at home. And I'm a huge fan of dreaming. And I think that it's crazy when people tell you to quit dreaming, because dreams are where ideas come from. And yesterday, the commissioner shared in her address the fable of the clever crow. And necessity is the mother of invention. And through the pandemic, there was so much need. I just hope that the innovation that we saw through the tough times, they don't go away when things get easier. We keep working, and we keep that spirit of innovation and working together at home with all of our providers, and our entire community keeps going. And that's what we're here for. That's what the Rural Health Association is for. We appreciate the support we receive. We encourage everyone to come out and join us in our to be the voice of rural health. I'd like to thank the panelists. Thank everybody for participating. I see we have some folks dropping off, but thanks to those that stuck it through. On behalf of the conference hosts, the Department of Health's Office of Rural Health and Primary Care, the Minnesota Rural Health Association, and the National Rural Health Resource Center, we thank you for participating in this year's virtual conference. We will be back in Duluth next year. We will not be stopped, darn it. We'll be there. We'll all be together. So we look forward to seeing you on the shores of Lake Superior in June of next year. And a reminder not to forget to submit your nominations. The link is in the chat box. You can go to the conference website for that also. Rural Health Awards will be handed out on National Rural Health Day, November 18th. So with that, thank you all. Thank you all for joining.
Thank you, Mark.
Look forward
Thanks,
to seeing you all
everybody.
later.
Thanks, Mark.